Dr. Karen Tabb Dina is kindly offering her perspective on today's theme, maternal health. Thank you to United Way of Champaign County, PNC Bank, Champaign-Urbana Public Health District, CU Mass Transit District, and our other sponsors for sponsoring this event.
It is an honor to present with you today for the YWCA Public Health Racism Crisis Lecture Series. Today I'm going to speak to you about a current crisis in our country and the topic of maternal mortality and morbidity. In this country, we are in a crisis where more women are dying each year during pregnancy and shortly after giving birth. We noticed a trend in the late 1990s where the maternal mortality rate that was going down began to rise with an upward trend of maternal mortality increasing. The United States is one of the high-income countries in the world where this trend is occurring, and we are not seeing this trend in other countries. Due to the rise in the trend of maternal mortality, the Health Resources and Service Administration launched a special report to look at maternal mortality historically in the United States during a 60-year period. This report found racial disparities in the Black-white ratio of maternal death. And while maternal death was going down across all races, a significant disparity remained. In the year 2007, the maternal mortality ratio was 34 per 100,000 births among Black women, compared to only 10 per 100,000 births among white women. This ratio is skewed by poverty and individuals living in impoverished situations. But that's not the only explanation. In 2007, our nation tried to address maternal mortality by looking just at the situation of poverty and how poverty could explain this rising trend over time. New reports from the CDC show that this trend remains upward, but those disparities for Black and Indigenous women in this country have been there for well over the past 2 decades. The purple bar corresponds to Black women, and the light lavender bar corresponds to American Indian Alaska Native women. What you will see over time is that the maternal mortality ratio is hovering around 40. That's 40 women per 100,000 women who identify as Black in this country are dying during pregnancy or after giving birth. This ratio works out to be 3 times, where Black and Indigenous women are 3 times as likely to die during pregnancy or after giving birth as compared to white women. These disparities are also magnified by age, where Black and Indigenous women over the age of 30 are 5 times as likely to die compared to white women. If we think of factors related to socioeconomic status, this does not explain the full picture either. If we're thinking about mechanisms of poverty and having disparate access to healthcare and to resources, we find that actually Black and Native American women with a college degree fare worse in terms of making it through after childbirth compared to white women without a high school diploma. So education does not explain these patterns that we're seeing, and education is not protective. Several theorists, 2 in particular from Harvard School of Public Health, Nancy Krieger and Arlene Geronimos, have come up with different theories. With Krieger, she's looked at structural inequality and racial discrimination among Black women and how that results in adverse birth outcomes and adverse problems for women. And Arlene Geronimos developed a theory called the weathering hypothesis, that among Black women, perhaps it was healthier to have children younger before their biological mechanisms experience more wear and tear from discrimination over the life course as women age. One factor that has not been explored as great as it needs to be is maternal mental health. Maternal mental health is a contributing factor to maternal mortality in this country. What we now know is that a quarter of women who die during pregnancy or the postpartum period are experiencing a mental health problem. And of these women, suicide is a leading cause of death, as well as drug overdose. If we think about the conditions that lead to perinatal mental health, we think of perinatal mental health problems such as perinatal depression, perinatal suicidal ideation, perinatal anxiety, bipolar disorder, and psychosis. Depression being one of the most common next to anxiety, where nearly 1 in 7 women are going to experience an episode of depression during the pregnancy or postpartum. Suicidal ideation is on the rise. Nearly 2 to 5% of women are going to experience suicidal ideation. Perinatal anxiety impacts as many as 1 in 3 women. Bipolar, very rare, about 1 in 100 women or 1%. And psychosis, the most rare, being 1 in 1,000 women will experience psychosis. This is important to consider because these conditions, if left untreated, result in adverse problems for mom and for baby. So we have known problems such as having preterm birth or low birth weight with untreated depression. Risk for mom, such as increased C-sections or maybe substance use or tobacco smoking with untreated depression during the pregnancy. Risk for impaired bonding with the infants. And in the postpartum period, risk to experience postpartum depression and or greater consequences such as suicide and suicidal ideation. Now, my research team has been investigating disparities in maternal mental health for well over a decade. And what we find is that there are disparities in maternal depression and suicidality when you compare Black women, Asian women, Black multiracial women to white women. So those disparities exist in terms of mortality, but then also of comorbid conditions during pregnancy, such as mental health problems. We've published on this work extensively, have a paper that came out late last year that looked at the reports of depression during pregnancy and suicidal ideation at delivery and found that Black and Asian women were reporting more suicidal ideation and depression when compared to white women. We conducted another study that came out early in 2021 in JAMA Psychiatry, and we looked at the trend of suicidality, that's ideation, thoughts of death or harm, and also actual attempts to end your life. And we found that this trend is increasing. Same as maternal mortality, the trend of suicidal behaviors, actions, and thoughts is increasing, and it's greatest among non-Hispanic Black women in our study. This is a call for concern. This is an alarm bell for us to follow up on mental health factors during pregnancy and the postpartum period among our Black, Indigenous women, and all women, but to really get at the crux of the maternal mortality crisis and make sure people have access to resources. During COVID-19, things are not getting better. Depression is increased across the board. If we look at countries such as Canada, Italy, Ireland, and China, they've all published findings on perinatal depression. We used to think that it was 1 in 7 women, but during the current pandemic, it's as high as 1 in 2 women. Pandemic-related stress, infection-related stress are all impacting pregnant populations. And anxiety is higher than we've known it to be in past studies, where 3 out of 4 pregnant people say that they're experiencing anxiety. There are solutions. There are several solutions in terms of public health solutions, policy solutions, and clinical practice solutions that we can move forward with to address maternal mental health and improve healthcare outcomes for women and their infants and birthing people across the board. Collaborative care is one of those examples. It's integrating mental health where people get their care, their usual care, their primary care, their obstetrics office, their usual care providers can receive support from psychiatrists to help them guide their patients through a mental health treatment protocol. We now know since 2019 that we don't need long course regimens for mental health treatment. Brief therapies are available. Problem-based therapies are available in as short as 2 sessions to help birthing people through the postpartum process and address mental health needs. Patient engagement is key. This is another approach through organizations such as the Patient-Centered Outcomes Research Institute, or PCORI. We're having patients at the table to identify clinical solutions. Hearing about the lived experience can improve outcomes for women and birthing people in this country. And partnerships are essential. So we have partnerships between researchers, communities, community agencies, and organizations to address the problem from a multi-pronged approach to make sure that maternal mental health is central in the maternal mortality debate, and that women of color in this country receive the maternal mental health care that they need and deserve, so that we can provide individuals with the support, treatment, and follow-up that they need before they go home with their infants and are left unaccounted for, resulting in a maternal death that was preventable and tragic. I want to thank you for your time. Thank you so much for listening today. My email is posted here. If you have further questions, please spread the word, spread awareness. We are all in this together to end this crisis and move our nation forward in the right direction.